Hey, everybody. Welcome to the Oddcast Podcast.
Off the record.
I'm Blackie.
I'm Erica.
And we thanks again for coming back. Hopefully, you've been here before and paying us another visit. But if not, hey, it is what it is. We hope you're new and checking out the show. Tonight, we're going to continue a conversation we had a few weeks ago with a friend of ours, Dr. William Robinson. And a lot of people know who he is in this chat. And we just had a few things we wanted to touch on him with. And I think he's got a few things he'd like to share with us. So, if you have any questions, again, put it in the chat. We'd love to hear from you. And if William can answer them or if we can answer them, that would be great. But in the meantime, here's Rusty.
Hi, guys. Thank you so much for having me again.
Oh, you're welcome. We definitely want to continue the conversation we were having on the last Healthcare Conspiracies episode. So,
well, you're welcome anytime.
Awesome. So we had talked about, you mentioned that you had a history in the medical field. You had previously known Dr. Fauci, and we were curious to hear your relationship with him, or, your work related, whatever you had going on. We'd like to hear about the history of that.
Sure. Tony Fauci has been around for a number of years. He's now 70 odd years old. At any rate, he was named the head of what's called the NIAID, our National Infectious Allergy and Immune Disease, or something like that, some combination of those. But that's sponsored by the NIH. So it's a federal position. And what that means is that put him in control of a fair amount of federal money that would be given out to grants to do research. So academic things. He was a true academic. He is a physician, is an MD, but he also has written dozens of books and hundreds of published articles, was very well thought of. He was actually his claim to fame is that when he was of age, basically, was the beginning of the HIV epidemic in America, or it started out being the AIDS epidemic before we knew it was HIV. Mm-hmm. And he helped develop some of the original drugs for that. He actually it became the head of the NIAID during that time. So like in the early 80s or so. And I met him then. Okay. So I was a junior faculty member at Tulane Medical School in New Orleans. So I also was a physician, but also a researcher at the same time. And one of my research interests then was in the effects of HIV in women, which particularly there were a number of malignancies or cancers that are associated with women who are HIV infected. And we had lots of them in New Orleans, where I was located at the time. In fact, we were one of the busiest places in the country at the time. So we published a number of things from New Orleans about the patients we were seeing and some of the things we were doing. And I ended up publishing several things and got funding for grant support for several things from both NIAID and the NCI, which is National Cancer Institute, which is another branch of the NIH. At any rate, I guess the first time I met Tony Fauci was in the mid-90s, it was about 95 or so. And we had just gotten funded for our AIDS clinical trials unit, which basically they gave us money, the feds gave us money to put patients on, HIV-infected patients on trials for new medications or whatever else we happen to be. And I was one of the investigators of it. So I was getting funding from that. I'll make that perfectly clear. I got about, I want to say total of about $20,000. And basically what that went to was to offset my salary from the school. So whatever I was getting from Tulane, basically they had to pay $20,000 less. I didn't get $20,000 extra dollars. Tulane got it. But anyway, so I had to go to Washington, D.C. for these meetings with the NIAID people and do presentations for them about, this is what we're doing. This is how we're spending the money. Here's been some of our results on these things. And I was kind of unique because there weren't many people doing research on HIV-related cancers in women. There's me and there were 2 or 3 other people in the country at the time. So it was kind of unique. So Dr. Fauci came to the first meeting I had to present at, And when I was over doing my when it was over, when I was done doing my presentation, I walked off stage. He walked up to me, introduced himself, shook hands, and talked to me for maybe half an hour about what I was doing. He was actually a pediatrician by primary specialty, so he had no clue about really what I was doing. So I had to explain it to him in some detail, but he was very nice and very appreciative, encouraged me, if I ever had any questions or, needed help with anything, to call him anytime. Gave me his personal office phone number. We didn't have cell phones in those days. And I did a time or two. I would call him and ask, here, we're doing this. We're trying to hire somebody in the schools, giving us a hard time. What should we do about it? Blah, blah, blah. So, I talked to him several times. And then again, when I presented one of our research papers on HIV in women at one of our big professional meetings called the Society of Gynecologic Oncology, he actually came from Washington to Florida, to Miami, where that meeting was, especially to see us, see me particularly, because I talked about the results of one of our clinical trials that the NIAID had funded. And it was on women, HIV-infected women with cancer. Basically, he made a special trip, to come, which was reasonable. His office his section funded the trial. So it was reasonable, but still, it was very nice of him to do it.
Mm-hmm.
So after that, or at that meeting, then we talked again for, another 30, 40 minutes. And again, he told me, call him anytime. And I said that ended up being the last time I talked to him. And that was probably 99 or 2000, right around there. And that was partly because everything, it was kind of the HIV epidemic, as you might guess, was in transition. We learned how to treat people with HIV better. The medications got better. It wasn't a death sentence anymore after a while. And people live with HIV for, decades now. And the cancer incidence in women with HIV went down also. So, I like to think we did something good there with that. So, but the point of that was that I just, it's not that I quit contacting him because I was upset with anything. It's just we didn't contact each other because we didn't have a professional reason to do so.
That's Gotcha. That makes sense.
I didn't hear about him, for years, I guess, until the COVID epidemic, and somebody shows up on screen. I remember I turned on the TV one day. I said, "Damn, isn't that Tony Fauci? Why is he even there?" I'm thinking of him. He's this pure academic. I would bet he doesn't even want to be there, standing beside the president, various other people, having to talk to, a group of politicians. That was the furthest thing from his mind. I can guarantee it. He would have no use for that, but somehow got thrust into that picture, for better or worse. So at any rate, like I said, I have not spoken to him since then, but that's when I heard of him again, or started seeing him again. And I think in retrospect, he made some mistakes that he would probably wish he hadn't. I think number one, he wishes he hadn't done it at all.
Yeah.
I would bet Tony would say, if I had a choice, I wouldn't have messed with that at all, because it was just a political fiasco. It was not a medical or a scientific issue so much. It was a political issue, and he didn't want to have anything to do with that. But what he did do, he didn't understand, I think, how to speak to politicians in this way, because he tried to speak to the entire country, when he was on air, as if he were talking to a medical school class. Basically, that was my take on it. He was trying to dumb things down for the public at large, because he figured, well, they're not going to understand what I'm, if I get too technical or too specific, they're not going to know what I'm talking about. So he made the mistake. The first mistake they made was not admitting that the lab in Wuhan in China had been funded by NIAID, and it had. Wow. And here's what happened with that. So the way it works is individual investigators around the United States write in grant applications to the NIAID to get money to do their research. Well, it gets reviewed at the NIAID, and it's competitive. It's real competitive. Anyway, they decide whether they're going to fund you or not. Not infrequently, if you get funded, if you're an investigator, say like me in New Orleans at the time, if you get funded, you can in a sense, subcontract. Say there is another lab somewhere else that does some particular technique that's highly specialized and that you couldn't do at your site without spending much more money, then you can subcontract. You can say, okay, such and such, if it were me, say such and such lab at MD Anderson in Houston is going to do this specific group of tests for us because we don't have the equipment to do that. And if we bought it, it would cost 5 times as much as if we just subcontracted it. So that happens all the time. And it happens all the time with some contractors overseas too. In other words, people are NIAID and all of the NIH investigators will have subcontracts with labs overseas. Most of them are either in Europe or Japan, but there have been some that have been in China as well, as obviously in this case. And Tony did not explain that well. He didn't try because he didn't think, A, that people would really be interested, and B, that they would understand. Now, I can understand that. That's a hard concept to explain what exactly is going on there. But it was not illegitimate at the time for a U.S. investigator to subcontract with an investigator in China in a lab in China for something they were going to do as part of the study. Now, I don't know exactly what it was Wuhan was doing as part of the study, but that's how the situation arose. That's how they got involved. Now, I suspect what happens, and this, again, is my opinion, or what happened, is that the Wuhan lab probably was a little bit less careful, a little bit less or proper about in their ways of handling, probably didn't have quite the same rules about how you handle infectious agents as we do in the US, and it leaked. I don't know that I don't think there was any intention of that. I think it leaked because they're just not as they don't have the kind of rules that we do. Our rules are much more strict than theirs are regarding handling those things. And I think that the virus leaked. And because China is the largest country in the world, and because people travel from China all over the world, it spread all over the world. So I don't think there was any intent on anybody's part to produce this worldwide pandemic and all the deaths that occurred. It was a sad, tragic, accident, in my opinion. But Tony didn't explain that to the public very well. It was almost as if he was trying not to say to the public what really happened, because I think being a full-time, long-term academic, he just didn't know how to say that on TV. That was never his strength. He didn't want to do it, and he just never figured out a way how to do it. So at first, he didn't even mention Wuhan in it. And in fact, when some people pressed him on it, some of the media pressed him on it, he actually said, no, we don't do that, but they did. And and he may not even have been completely aware of that. In other words, he might not have known. He administers hundreds, if not thousands, of grants. So that was not at his fingertips, that there was this NIAID study in whatever lab it was in the US that subcontracted to a lab in China. He wasn't necessarily even aware of it initially. I can't imagine that when he found out that Wuhan was involved and that that's where the leak probably started, that he didn't get it pretty quick. I would bet he understood, but he didn't know how to explain that to politicians or to a TV audience. I think he tried to some degree to, I hate to use the word cover it up, but he just didn't want to say it. I think he kept thinking, I suspect, this is just going to blow over before too long. And I just don't want to get involved in this. I'm not going to bring all this stuff up because it's nobody's fault. Nobody was trying to do anything wrong. Now you can look back in retrospect and say, well, maybe we shouldn't have been working with Chinese labs to begin with, but that's a separate issue. At any rate, when they finally held Tony's feet to the fire about Wuhan, he finally admitted it, and said, yes, they were a subcontractor to one of our grantees. And yes, they had access to this virus. And yes, they were doing research that could have resulted in an altered form of the virus that would be more aggressive and more infectious and more lethal. And yes, that's a possibility. That's where it came from. And I think since then we've probably figured out, yeah, that's almost certainly where it came from.
Yeah.
So I think it was just a combination of awful circumstances. Because I can imagine myself in that situation, having to stand up there and try to explain that to people.
Mhm.
You can't do it in a sound bite. That's the problem. You can't stand in front of a TV or media guy and say in one sentence what happened. And that's what they want you to say. And it just can't be done. And he didn't want to do it, never wanted to be there. I mean, I get it. So I guess in retrospect, what I'd say, Tony Fauci is a highly respected academic. In fact, I can tell you, he was one of the principal authors on the study of the drug called AZT, which is azithromycin, for prevention of the passage of the virus, of HIV virus, from mothers to children. And what we found out in that study, which we participated in my institution, was that if you give mothers the drug AZT during pregnancy, it reduces the risk that the child is infected by like 90%.
Wow.
And that was a real big deal then, because in those days, this was late 80s, early 90s. The mortality rate for a child born with HIV that was transplacental, in other words, caught from the mother or transferred from the mother, was like 90%. So undoubtedly, that saved hundreds, if not thousands, of children's lives by keeping them from being born with HIV. So, if nothing else, he deserves great, kudos for that. And he's done half a dozen other things that are on that scale of good things, that have come, from him. So he's a good guy. He's a tremendous scientist, academician, physician. He was not comfortable on a political stage. He probably should have just declined to speak and appointed some kind of a spokesman instead of trying to do it himself. And then when he got there and tried to do it himself, he didn't realize how big a deal this was going to become. And he should have been more transparent from the start, and he wasn't. And so, like I said, I think he made some mistakes. I don't think there was any ill will. I bet he feels awful to this day, after all of this. So, he is not entirely blame free in this. He didn't handle it well at all. But at the same time, he was basically a good guy caught up in a bad situation. That's the summary of it.
Do you think that, I know he spent hours and hours and hours in front of Congress, and I know that gets politicized as well, but obviously, but I know him and Rand Paul had quite a few, I guess, conversations about the leak and who was funding the organization and all these other things. And I watched quite a bit of those. As boring as those were, I did watch quite a bit of those. And I think what most of the American people, I think their problem with Tony Fauci is that they felt that he was lying the whole time about all of this.
Right.
And I can't, in watching multiple congressional hearings and hearing him say something here, then kind of contradicting what he was saying over here, and another, it just kind of, and a lot of people watched that, and a lot of people picked up and said, and I agree, it was politicized 100%. I also think that, in my opinion, that, if you look at COVID and the flu, I know a lot of people, but the flu disappeared when COVID came about. And I think that maybe, we know that the flu is a form of COVID. It's a different number.
Different virus. Yeah.
Yeah. So I think maybe it was stronger. I know my father was put down, not put down. My father was put down. No, on my father's death certificate, I specifically told them that I didn't want them to put COVID on there because my father had COPD. He survived kidney cancer. Was it kidney? Yeah, you have two kidneys. Survived kidney cancer, and he had so many things wrong with him. But when I went to visit him in the hospital, he wasn't coughing and hacking and anything like that. And that's why in the last episode, I asked you about numbers. Hospitals, for COVID deaths, were they getting money for it? It's been proven. And you said something about pretty much every death, they get something, right?
Yeah.
So that kind of, and that, the American people saw that too, not just America,
Oh, yeah.
all over the world. And so
Tony
that
Fauci was not the only person who handled that badly.
Absolutely. I think just about everybody handled that badly. Dr. Birx, Fauci,
Yep.
I forget who the Surgeon General was at the time. There were so many people that and I think that was a big problem, was it got politicized so much. This team wants to go against this team, and then it just got out of control, and everybody, it was something that tore families apart.
Yep.
It really did. It just, now my mom, being a nurse, she was like, in the beginning, like everybody, a little bit like, oh, maybe this is something really bad. But as time progressed, none of it made sense. Here we are, 6 foot distancing. Why did Fauci tell us 6 foot distancing, and then later tell us, well, it wasn't real? I just, okay, well, that's not helping your it's not looking good. And then, because I always said, they tell us to stay 6 feet apart, and then you can wear a kerchief over your mouth.
Right. And there was no data that really supported that.
Right. And I think that's where, a lot of the conspiracy theories came from, is that people were like, no, wait a second, here we are, for certain diseases, you have to wear biomedical, big mask. You've seen people even in operating rooms, and they've got the big old masks on and the shields and everything to protect if it's some kind of chemical or something serious as a virus wise. And here we were told to wear, just cover your face. I can remember going into a hardware store back in Dayton, and I walked in without one, and I'm like, let's see how this works. I walked in, and then I looked down an aisle, and there's another gentleman walking around with them, and nobody really stressed anything at that time. So I'm like, okay, I'm not wearing a mask. Now, we bought some, but if you look at the masks we bought, it was made by some lady, sewing clothing together.
That's what most of them were.
Yeah. And you're like, well, this makes no sense at all. Why? And yeah, Misty, let me click on that.
But I mean, at work, I had to wear a mask.
Yeah.
A lot of people had to wear a mask, or.
Oh, I did. Yeah.
Or else.
But the irony that we all knew from the beginning was that those cloth masks did nothing. You had to have a so-called N95 mask, which actually has a microfilter to filter out the viral particles. A piece of cloth won't filter out those viral particles, so they were pointless. But again, the reason Tony said that initially, because there was nothing else to say. Nobody knew, what are you going to, I can guarantee you, he could, if he got on there and said nothing, what should we do, Dr. Fauci? Oh, nothing you can do. That wouldn't have gone well either. So he felt pressured to say something. Well, what do you say? Well, I guess common sense suggests if we stay away from each other or if we wear masks, maybe that helps. I mean, I basically think that's what that turned out to be.
Well, then I think it got politicized so much that people just started. I mean, he might not have even said anything. I'm not sticking up for Fauci. Just so everybody knows, I don't know Fauci. I could care less about Fauci. He's William's friend, and
he's retired. He doesn't care anymore.
They have a relationship. I think that a lot of stuff happened not just because of Fauci, but because of a lot of politicians that had ulterior motives in their minds.
Sure.
And that's how it's always going to be, ladies and gentlemen.
No question.
So trying to think. Yeah, we all had to wear masks. We were supposed to. I know I worked tool and die at the time, and we were considered essential. And our company didn't make us wear masks. They were like, take your temperature every morning. Here's hand sanitizer. And if you called in, and said, well, got let's say a 99.2 temperature, and it's like, okay, that's whatever, 11 days off or whatever they gave you.
Right.
And you're like, but in the beginning, a lot of businesses weren't paying for that, because they didn't have that, PPP loans or whatever to keep. So a lot of people I being one, got over a week off without getting paid. And then the next guy that got sick, or I did get sick. The next guy that got sick, he got the 11 days off, but he got full pay for it. And it's because the PPP hadn't been issued yet. And so, I know Misty put control, and yes, Misty, we've always had to go through a lot of things that are trying to control us. And, I'm a pure blood. My wife's a pure blood. I had the vaccines when I was a kid for whatever they were. I forget what they were for back then, but, the problem with what just happened, Doc, is, in fact, Dr. Rusty, is that this has really caused big effects in the industry as far as people getting vaccines, because
it's a trust
absolutely.
issue. That's
absolutely.
what it is. People lost trust in the authorities who were talking to them at that time, including Tony Fauci, but also lots of other authorities as well. And that lack of trust has transferred to a number of other things associated with medicine, including the vaccines.
Yep. It's funny because you look at, a lot of what's in vaccines are coming out, whether they're true or not. We're hearing mercury, we're hearing all these different things that are in vaccines, and it's really turning, I guess, to be nice, you have your people that are sheep that'll do anything they're told. And then you have people like us that will question everything we're told, because I feel you become a better person if you question everything. And again, that's my motto, question everything. And so I think, unfortunately, this incident has hurt. Anytime a major disease or virus ever happens, that there'll be a lot of people, and probably be me, me as well, whether it's serious or not, there's going to be a lot of people that aren't going to take a shot or a vaccine because of what happened with this one.
No, you're exactly right.
And that's
severely damaged the American public's trust in the medical industry at large and the government's utilization of the medical system, particularly in the form of vaccines.
Yep. So, okay, ma'am.
I wanted to talk about billing. I know that we discussed this in the last episode, but billing for, sickness and procedures and injuries. But as far as COVID, and I know this wasn't your field, but did you see or hear, or whatever you want to talk about, that billing might have been elevated, if you want to say, or related to it? Or
it was, yeah, for sure.
And then, some of the things that we had heard. So really the worst part, not the worst, but the nail in the coffin, kind of, I feel like, was being put on a ventilator. Seemed to be, you probably weren't making it off the ventilator. Yep. Is usually what we would hear. And that's actually what happened to Chad's dad. But I just, in your opinion, if you want to share, who benefited from that, the way that the billing would have gone with that?
I'll put in a plug for my last two podcasts where I talked about billing, medical billing, and how the healthcare system works in great detail. But just to make it a short version of that, yes, particularly the hospitals and insurance companies benefited, because when COVID came around, there was a new code created for that as what they sometimes call a DRG, or diagnosis related group. So that's a diagnosis that you can use, and and there's a number for it, actually. So when you send in your bill as a hospital or whoever to whatever insurance company, you write that number for that code, for the code on that bill. And you're not only are you more likely to get paid, you'll get paid something specific for COVID. In other words, say if you put down a code of, say from my standpoint, cancer of the cervix, they're going to pay you X amount of dollars for that, no matter what, basically, or Medicare and insurance companies. Mm-hmm. Well, if you put down COVID, plus cancer of the cervix,
Mhm.
and you put COVID as the primary code or primary diagnosis, and then put cervical cancer second, the primary diagnosis is the one they pay off of.
Okay.
So if you had somebody in the hospital who, say, like Chad's dad, had COPD, had kidney failure, whatever other else things he had, probably all of those things contributed somewhat, to his decline.
Mhm.
And if he had COVID also, it was financially made sense for the administrators to code COVID first, because they get a little bit more money than if they coded COVID third or fourth.
Mhm.
Now, that doesn't mean that, and I will defend them to some extent. That's not illegal. That's exactly what the system is designed to do, which is the point I kept making in my podcast is, it's the system that's the problem.
Mhm.
Okay.
Most of us as individuals, it just exists within that system because we don't know how to do anything about it.
Mhm.
So what is the hospital supposed to do if they look at the Medicare rules, and Medicare rules say your first diagnosis, you're going to get paid for X, but for every secondary diagnosis, you're not going to get paid as much. Well, you're going to put the highest paying diagnosis first, of course. That's good business in a sense. That's being fiscally responsible in a sense. So that happens. Yeah, that does happen. And there are probably other ways because I'm not a hospital administrator. I don't know that business all that well. So I'm sure there are other ways, and they manipulated it too. But that's the easiest way, I think, and probably the most common.
Well, with what little I know about medical billing, I know it's kind of like a series can be associated with a diagnosis, or also, it's kind of like a directory. You have this, so like they would have started out with COVID, and then whatever else follows it. But
Yes.
also, just in general, I know that your billing can get rejected if you don't have all of the codes in a certain category, for this specific diagnosis or treatment.
Or if you put two codes together that aren't supposed to go in the same DRG or diagnosis related group, they'll kick it back to you and you have to start over again.
Right. So do you feel, or did you hear that, because we heard it, and it probably is true, but that death from COVID, probably that medical facility received more money because it was due to COVID or related to COVID.
Just because of what I said. If you could put COVID in the diagnosis, you got paid at a different rate.
So I want to say, and we'll type it in chat also, but we do want to recommend your channel, which is The Blues Doctor Recommends. That's Dr. Robinson's channel. And he has a fantastic YouTube show. It's great.
It's super informative medically, and it's super informative
musically and culturally. It's a very interesting. So yeah, but I'm gonna say
Patrick's got a question.
Yeah, I was gonna say that's a good question that Patrick has. It's in the chat. Who says what pays the most? Patrick, that is that's the $1 million question. Basically for Medicare and most private insurance, at least in part, base what they do off of Medicare. There are these committees of physicians and hospital people and administrators and so forth that decide how much the individual codes are worth. So I used to serve on that committee, and what happens is 3 times a year, these committee members, there's probably 20, 30 of them from all over the country representing most of the different specialties, go to Washington, D.C., and you sit down in a big room and you discuss various codes that come up with time. Because there's this huge system of codes that has been in existence since 1992. That's when the current system started. And we go over those codes over the years as they change in some fashion. Say a particular procedure, a surgical procedure changes because we figure out there's a better way to do it. Then you might want to change the code to add value or maybe take away value from it. So that's what that committee does. They add or subtract value to whatever the diagnostic code is. And you know how they do it, Patrick? It's whoever shouts the other person down the best. Honest to God. So, for example, I went there, and my specialty is gynecologic oncology. So there's not many of us there. And I had to go present a code on something called intraperitoneal chemotherapy. So this was a new method, relatively new at the time, of giving chemotherapy to a woman with ovarian cancer by placing it directly into her abdomen. In other words, not through an IV, like it's kind of the traditional chemo, but directly into the abdominal cavity. And you have to have a special kind of a port or catheter that you put into the abdominal cavity. And it takes like one-on-one nursing care because it's pretty complicated. So what we wanted to do was to get more value for that code than a simple IV chemotherapy, because there was lots more involved. We had to spend more on nursing care. We had to spend more on putting the port in. So it was way more way more expensive to do it. So we went to the committee. My professional society proposed the code. I was the chair of our coding committee at the time. So I went to Washington and presented the code to, it's called the RUC committee, or RVS update committee. I think that's what it is. And I'm sitting there, I might presentation, I'm gonna do it very scientifically. I'll say, okay, here's what we're doing. This is why it works. And I showed like figures on the better survival that's associated with intraperitoneal chemotherapy versus IV standard to show that this is a good thing. And I showed I had lists of, what it was costing us, the expenses for, and so forth. And so after I made my presentation, then we were allowed to ask questions. So the orthopedic surgeons in the room, and there were two of them, first off said, well, there's not that many people get cancer of this kind anyway. Why are we even arguing about this? And honestly, that's how they do it. They will argue because if it's a zero-sum game. Now, there's X amount of value, and that's mandated by Congress there that they can play with. So if I get more value from my code, it's got to come from somewhere. It's got to come from somewhere else. So everybody, all the different specialties are pitted against each other to maintain, revenue for their own specialty. Well, luckily, there was a nurse practitioner on the committee who had been an oncology nurse. She stood up and told them off, basically. She said, this kind of a technique is very complicated and it's very labor intensive. That's ridiculous to say that, just because there's not as many ovarian cancer patients as there are patients who need a new knee replacement, that the code itself doesn't need more value, doesn't deserve more value. But just based on her testimony, basically the committee went for it. So that's really all it is. It's whoever can make the best argument to this group of 25 or so people that they will buy. So it's like convincing a jury, kind of, who deserves what. It's a fascinating thing. Yeah, it's amazing.
Yeah. Let's see what I was going to go to next. I want to say real quick about COVID. We each had it once, and very early on when things were developing, and I had to get tested for work, and we went to an urgent care, and they said I was positive or whatever, and so she was doing the oxygen check on me, and she was like, you need to go to the hospital right now because your percentage is so low. And, I was thinking, I'm like, how do I feel right now? It's hot in this room right now. It's a very small room. I can see that, I'm not claustrophobic or anything, but I felt like maybe my levels might be a little off. Yes, I'm sick, but it's not an ideal condition right now. I'm like, let's judge this. I don't feel like it's hospital worthy right now, but it just struck me as odd how it felt like pressure from her that she was trying to elevate this to a stage I did not feel was appropriate. So
I can remember when the nurse told her, I don't know if she was a nurse or a nurse practitioner, but when she told Erica that you should go to the hospital, we were walking out, and I looked at her, and I was like, how do you feel? And she's like, I feel fine. I was like, well, then we're not going to the hospital.
Yeah.
You know, because
And I can tell you exactly why that kind of a thing occurs. So she saw you, and you did probably an oxygen saturation test. They put one of the things on your finger, or they did
Yes.
something like that.
Yes.
And the number that came up for you was below a certain threshold that they're trained they should be concerned about. They're more worried about that number than they are about how you feel. I mean, ideally, they would say, oh, geez, yours is a little low. So what's going on with you? Are you feeling okay? And then you try to put that together, you know, in a comprehensive fashion, but they can't do that in those kinds of settings. You know, somebody who's just a nurse aide or something like that, they just can't do that. They are told, because of liability, honestly,
Right.
if somebody has a number below X, then you send them to hospital, period. Because we can't assume that liability if they don't. If you don't tell them to go, or if you tell them to go and they don't go and go home and die, then it's not our liability.
Gotcha.
That's why that happens.
That's a good explanation. You know, we talk about that, and we've talked about how everybody is so happy, and that's probably a lot of the reason of why it's so expensive to go to the doctor or to get
part of it.
treatment to cover insurance.
But you also have to look at, okay, so she sends you to the doctor. Now to the hospital. So you go to the hospital. Now we have to pay insurance.
Oh, yeah.
We have to pay all of that. And in the meantime, you're not feeling any different than you normally felt. I remember because she had the test, and then they were like, "Would I believe they did the same while I was there?"
Yeah.
And I'm like, "Okay, yeah, you can test me." And they tested me, and they're like, "You have COVID too." And I'm like, "What?" You know, I feel like normal. I don't know. So that's when as we were walking out, I said, "Do you want to go out?" And she's like, "No, I feel fine." I was like, "Okay." And then we suffered a little bit, I think, from headaches, and I don't know. I had headaches and maybe a temperature, but nothing. I've had the flu way worse than I had COVID. So, you know, that was something. And I think that's like right now, a lot of the things I'm reading, you know, I understand completely 100% with what people are saying about, you know, we had to shut down schools. If you didn't get the shot, you lost your job. If you didn't get the shot, you know, you lost scholarships, you know, all of that. And you look what's happening with the military as well. All these military people that got let go because they weren't taking the shot.
Right.
And now they're all getting, you know, they have the ability to rejoin because they realize that it wasn't what it was. It wasn't. Yeah. So
that was not the right response.
I have two other things to say about COVID, and then I'll let that, we're going to move on to a different topic because I feel like we can have at least a whole episode on that. But it is, I'm curious to see how much the vaccines have changed because looking briefly, all of the regulations, it seems, regarding the vaccinations and back then, what was required or what was considered best is it's all different now, it seems. And so I would like to, just for my own research, cover that and see out of curiosity. But the other part is that it struck me as very desperate back then to see all of the incentives that were offered to anyone who would take a vaccination.
Absolutely.
And it came from, it came from employers, baseball teams. Let's see, who
politicians,
else? Bars. It's just like it was. You know, it's so weird how you would go to the store and say everybody in the store had a mask on, but you're just at the grocery store and just seeing people's eyes, they could look so judgmental on everything.
Oh, yeah. Yep.
You know, it was just crazy.
People against each other.
Yes. So we'll save that. We'll do a whole episode on that. But,
you know, I will say about, and I must, to be devil's advocate in a sense, COVID is and was a real thing.
Mm-hmm.
There were a lot of people who died. My 34-year-old nephew, who was otherwise completely healthy, died. of COVID. No question about it. And many other people did too. So it's not, COVID was not, nobody made up the fact that COVID was very deadly. It was.
Oh, I agree.
And I think the thing people are hung up on is how much our government tried to, control the response to it without really knowing what the right response was. I don't know that we still know what would have been best to do in that situation. I can't figure out what would have been best, but clearly what we did do was not good in a lot of ways. It's not because COVID was not a real thing. It really was.
No, I would not say
that's not a conspiracy.
Yeah, I don't think that's a conspiracy theory. The conspiracy theory lies in it. Was it lab borne? Was it a bioweapon? And there's so many different conspiracies you can look at.
Oh yeah.
If you look at the amount of people that it took out, all over the world, you can look at it as a bioweapon, and who it took out were mostly the weak people that were immune compromised, that were old. Again, go back to conspiracy theory. I guess the New World Order wants a population to be a certain size, and what's a great way to wipe out a population is with disease. I still say that was AIDS. I still say there was a lot of diseases that were man-made or not man-made, whatever, either or, but they were there to wipe populations of people out. AIDS was homosexuals, druggies, and I think that, and other immune compromised people. So, we could go, that could be a whole.
Oh yeah. Oh, lots of stuff to talk about with HIV too, because we had such an experience with it in New Orleans, and we were kind of unique here in how the HIV epidemic came to be in New Orleans. So I could talk about that for a long time.
Yeah. And again, it's we look at conspiracy theories, and I'm going to touch on this before she gets moving on to something else. And we're starting to find out that a lot of these conspiracy theories are starting to come true. We've done the weather episodes. People are learning that the weather is being manipulated. We're learning that there are companies that manipulate the weather. Now, you can just say that they're seeding or whatever, but they're manipulating the weather. So, it's tit for tat there. But my pillow that I'm trying to sit higher than Erica is falling out. But
he's not going to let you live that down, Erica.
Yeah, that's okay. But anyway, I'll let her go on. And
so I have a question for your opinion on medications and over medicating. If doctors over prescribe medications, if you have an opinion on that, and more specifically related to, do you think that could have been a lot of the beginnings of the opioid crisis?
Yeah. Oh, yeah. And yes, people or medications are overprescribed all the time. And I will say in the chat, Misty says sorry to everybody who lost folks, including me. So I do appreciate that. But yes, there's no doubt people are over medicated. I'll give you a great example. My mother was in assisted living for a number of years before she died. And she'd been seeing an internist. She'd been seeing various other specialists, all of which had her on something. So she ended up taking a dozen different medications. I didn't even know what all they were. At any rate, we finally managed to get her in to see a specialist in the elderly, what's called a gerontologist or geriatric specialist. And he was great. First thing he did was say, well, what all medications are you taking? And she had this sack full of however many pill bottles, 20, 30. And the first thing he said was, that's a lot of medications for a tiny little woman like you. Let's see if we can't take care of that. And he whittled it down to just a handful from there. Wow. And, it didn't hurt her at all. Maybe she did even better. She ended up living several more years. So there's no doubt. I think the reason that happens is the relative lack of communication between physicians and practices and hospitals. We make such a big deal about the electronic medical records that everybody uses now. Well, the problem with the electronic medical records is it doesn't make it easier to communicate between physicians. It makes it harder because each electronic medical record is proprietary. So there's an owner that makes a profit off of it. they're not going to share their record with somebody else without that other person paying for it.
Wow, I did not know
Everybody has
that.
all kinds of different electronic medical records that don't communicate with each other.
Wow.
So, and even before the electronic medical records, physicians were notorious about not communicating with each other. It doesn't pay physicians to do that. In other words, say if your internist, or here's a good one. So a little old lady, elderly lady like my mother, had half a dozen different illnesses, basically. And she went to, say, her neurologist who had been treating her for, say, Parkinson's related disease. And he had her on a couple of things. And then she went back to the internist who didn't know what the neurologist had given her for Parkinson's and gave her something else that kind of interacted with that. And because the reason is the neurologist doesn't get paid to pick up the phone and call and have to talk for an hour. By the time you call the office, get the other physician on the line, tell them what's going on, do all that stuff. It's 30 to 40 minutes out of your time that you're getting zero revenue for. So there's a financial disincentive to physicians to do that. If you're already overworked as a physician, in other words, say you're seeing 25 patients in a day, are you going to take another 4 or 5 hours to call the individual doctors and tell them, okay, here's what I did? I mean, hopefully you do it in the situations that are really needed, but you can see there's a terrible disincentivization to doing that because it doesn't pay and it takes up time.
But what about other office staff? Can't they assign or ask other office staff to confirm medication?
To some degree, but even then, you have to pay them somehow. And for something like that, or here's what would happen. They will get or you would tell your office staff to send the medication list that we generate to Dr. So-and-so so that they'll know what we're taking. Well, you know what happens with that? That list goes to, it used to be by fax. Now it goes mostly electronically. And that goes into the electronic file, which is mountains wide. And it never gets seen again.
Well, how about the role of the pharmacist? That plays a part too, right?
I'm sure they try. And I've talked to some pharmacists about that. And they do try. But there's only so much they can do. What they have to, and because it works there, that affects them too. So say if they see 2 medications from 2 different doctors and they think, well, why is she on both of these medications? This is not a good thing. Then that guy, the pharmacist, guy or gal, has to pick up the phone and call the doctors. That's an hour out of his or her day that he doesn't get paid for. And that his other work that he's being required to do by his employer is not getting done. Mm-hmm. So there's a disincentivization to that. That's a lot of syllables in that word. But yeah, that's why it's so hard. Our system, again, it's our system that makes it hard. It's not the individuals within the system for the great majority. I mean, there's bad apples everywhere, but the great majority of healthcare workers, physicians, nurses, pharmacists, and most other people are not out to do harm, or they're not into it really because they're going to make a lot of money. Yes, there are exceptions. It's because our system works so poorly because it's developed so poorly over time. And if you want to hear about how it developed over time, go back to my podcast from 2 weeks ago, and I go into detail about that then.
Okay. Again, let's push Rusty again.
Yeah, we have new people in the chat. I've noticed that. So the Blues Doctor recommends, you can find Dr. Robinson on YouTube. And it's the Blues Doctor recommends is his channel.
And I see in the chat, Patrick says, and this is absolutely true. It's sad the dollar can make you or break you health-wise. Mm-hmm. And that's absolutely right. I talk about that to some degree. And this past week's podcast just came out. I used to have to sit in my office and make decisions about what I was going to treat people with based on their insurance coverage. In other words, say if you have advanced cancer of the cervix and you have private insurance or you have Medicare, well, I can treat you in that case with the standard medications of the day. And there's basically 2 of them. One of them is called cisplatin. One of them is called Avastin. Cisplatin has been around for decades, and it costs like pennies. to give. A 6-month dose of cisplatin is maybe a few $100s, maybe. Then there's another drug called Avastin that we found in just the last 10 years that is extremely expensive because it's molecularly targeted and designed. I know it was created in a laboratory in a sense, but it's very complex and it costs 20 times as much money. The standard we figured out via clinical trials is to give people both cisplatin and Avastin. They will live longer if you give them both of those drugs.
Okay.
But if you are uninsured or underinsured, nobody's going to give you Avastin. You can get cisplatin, in the hospital or the pharmacy or whatever will eat that, but they're not going to eat $10,000 a dose.
Mm-hmm.
And that's exactly what happens. So I had to sit in front of people, say, and here's even harder, and I'll put up a whole new can of worms. An illegal alien comes to me because I was in Texas for a long time. We had immigrants from Mexico, and it was fascinating that I would have, say, people who had lived in our community in Texas for many years. They would bring grandma up from Mexico when she got sick.
Wow.
So I would have patients, grandma gets cancer of some sort. They bring her to see me. She's not a citizen. She doesn't have any insurance at all. What is she going to get? What am I going to give her? And boy, that was a tremendously difficult conversation to have. And that's why I say that's why our system is so badly broken.
Mm-hmm. Let's see. Out of curiosity, you were talking earlier about the trial patients. What is considered a trial patient, or how would you qualify for that?
So what clinical trials are basically just, a test in a sense to find out which is the best drug. And they can be funded by the federal government, like the NCI, or they can be funded by industry, like the big pharma companies, Merck or various others. They can be funded by private, say, foundations, nonprofits, which they do sometimes. At any rate, so what you have to do to get a trial is your institution has to decide, okay, we want to participate in this trial. So then you have to get it approved by let's go what we call an IRB or what's the best way to explain this? It's basically an ethics board that says, yes, this is an ethical study to do. We're not putting anybody at risk. And IRBs came to be in the wake of the Nuremberg trials when, the Nazi Germany experiments on people. So we have a very complex and demanding system for ethics in research too. So you have to pass that first in your institution. Then you as the doctor can offer the trial to a patient. Say if I saw a new patient with cancer of the cervix and our institution has a trial, and we could have used platinum and Avastin, the trial would have randomly assigned that patient to either cisplatin by itself, which was considered the standard therapy at that point. So that's perfectly ethical because that's the standard, or cisplatin plus Avastin, which we think may add to survival. We got some preliminary data that suggests, this may work, but we don't know for sure. And that's the way you pitch it to the patient. And most patients in that setting will say, yeah, I'll go on the trial. And so they get randomized. And there's a computer that in its essence flips a coin electronically and assigns the patient to one or the other. And once you know what they've been assigned to, and cancer trials don't use placebos very much because it just doesn't work in a cancer setting. Mm-hmm. So you get assigned, say, to cisplatin only. Well, okay, then you give the cisplatin and you continue to follow that patient for a year, 2 years. The other patient gets cisplatin and Avastin, and you follow them exactly the same way. In other words, the only difference being one patient got platinum plus Avastin, the other one got cisplatin by itself. And everything else is supposed to be identical in the patient. So in theory, there's no other factors that affect it. And then you compare the outcome. With cancer, it's kind of easy because you can compare just survival in many cases. So if the median survival, say and I know this off the top of my head, for cisplatin by itself in a woman with advanced cervical cancer, the median survival was maybe 8 or 9 months, something like that. The median survival of cisplatin plus Avastin went up to nearly 20 months. In other words, it really made a significant difference. And so we, and that was an NCI trial, we did a press conference and talked about and presented it all over the country to physicians everywhere, saying, okay, we believe cisplatin plus Avastin should be the new standard for treatment for women with advanced cervical cancer. That's how those trials work.
So you said the medications are randomly selected or assigned.
Yeah.
What about the patients? Are the patients randomly picked?
It's in a sense, yes. For physicians who want to do clinical research, basically any patient that would come to me, if they had cervical cancer, I'd offer them to trial.
Oh, okay.
Now,
okay.
not every patient says yes. So in a sense, it isn't random. Some patients, for whatever reason, will say, no, I don't want to participate. And I've had people tell me they don't want to participate, and they can't tell me why they don't want to participate. So there's a whole philosophy behind that also that's completely separate from this. So the patient can opt not to participate if they want to. I prefer, and most of the rest of us who participate in clinical research as a routine would offer it to essentially all patients who had that particular diagnosis.
Okay. And when you said that the patients they weren't really different, is that their condition and what stage of cancer they were in, or not so like body build or anything?
No.
Okay.
It's like what stage the disease is. And there were some exclusionary things, like if you were, say everything was equal, but you came in and your kidney function was very poor. In other words, you couldn't metabolize cisplatin at the rate you need to metabolize for that to be a safe drug. Well, you can't participate in the trial. That's not fair to do that.
Yeah.
So there certainly are some guidelines or rules about who can participate based on individual lab values and a few other things.
Okay, that makes sense. I've got one more topic I'd like to cover with your, and especially you do have experience with this, so I'd like to get your insight. But as far as maybe conspiracies or how you feel about it, but cancer, and do you feel there is any push for a certain medication? I know this can be different, types of cancer and different stages of cancer, but do you feel, other than the studies you have done, do you feel that they prefer medications or chemotherapy over natural treatment?
That's not what I thought you were going to say. I thought you were going to say, would physicians prefer one medication over another if there's no clear difference in outcome? And that is true, because some medications pay better than others. And some doctors do that. And that's not the way I do it. But there are physicians who will prescribe one chemotherapy drug over another, because the one chemotherapy drug has more of a profit associated with for the physician than does the other. But anyway, do they push it over more natural things? Yes. The short answer is yes. Physicians do that because they simply don't know about that. That's minimally covered in medical school or residency. We talk very little about natural or non-pharmacotherapeutic regimens. So most physicians really have very little idea. I'll tell you the way I handled it, because patients would sometimes come in and ask me, should I take thus and so? And I would look at it and say, and sometimes they would tell me, I want to take this. Okay, I'm not familiar with it, but what information do you have with it? I'll be happy to take a look at it. And I would. And I would point out to them, okay, there's really no clinical trial, randomized clinical trial that's truly objective showing this, whatever you have, works versus this drug that we know works. And so the way I would do it, I would say, I don't have a problem with you taking a natural medication, whatever you think it is, if it's not likely to hurt you, and most of them are not, as long as you don't discount or not take what our standard is. If you want to take that plus the standard, I would much prefer that. I mean, I've had patients who just wouldn't, who just wanted to take what they wanted to take and have. And when I had that situation arise, and I'm sure not every physician did this, but I would tell them, okay, if that's what you want to do, I can't prescribe it to you, but I will continue to see you. So go for it. You're welcome anytime to come back. Let's make an appointment for 3 months to see how you're doing. We'll do your blood test then, blah, blah, blah. So I wouldn't kick them out for that. And some physicians would. I would just keep following them and just document every time patient is offered the standard treatment. They've declined in favor of thus, and so we're continuing to follow. That's
incredible, because you were still monitoring the growth of the cancer. Right. But you were supporting them as a patient with their choice of how they wanted to treat it.
Yeah. I mean, autonomy is certainly the most important component of that. If an individual wants to do something, I as a physician cannot overrule their right to autonomy.
And that's good. Awesome. I mean, yeah.
Yeah, that's very good. And there were a few different ways I was going to word my question, but it just landed. And then, so there do exist doctors who may just prescribe a specific medication because it pays a certain amount, like that would exist. So that I love what you said.
In cancer, particularly how it happens is when new medications are put on the market, say a drug company has this new medication, they have a window where they maintain the profitability, and they can't, no other company can make that medication. So it's a proprietary thing for a certain amount of time. Typically, it's 17 years in the US from the time they start working on it in the lab to the time the clock starts then. So say if it takes you 10 years to get through all of the clinical trials, and it might, then when you get it truly approved by the FDA for market, you've got 7 years where your company has exclusive right to that drug. Well, they're going to charge way more for that drug during those 7 years, because after that, a generic is going to be made by some other company and the price will drop dramatically. Well, during that time also, say if you as a physician, the oncology doctor, owns your own pharmacy, then you will get the profit. You get a much higher profit from that drug that's in that window than you would from a generic that's not in that window, even though they're really the same drug. So yes, you can, both the companies and the physician, like a physician-owned pharmacy, which many oncologists do that. They own their own pharmacy for doing cancer drugs, because most commercial pharmacies can't do chemotherapy. It's too complicated for most, like at Walgreens or something to do. So you have to create your own pharmacy. But if you could buy a drug that is still in the protected window, you're going to make a lot more money on that than you would buying a generic, which is going to be less than half the cost. So that, and I guess the point I was making is that, yes, there are ways for both the company and the money to make money, and the oncologists and the pharmacies to make money. And I think I agree with that, because it's it's almost like what's the right thing? Not like a PHI. It's protected knowledge. It's like a copyright. In other words, if you as the drug company put all that time and effort and money into creating this drug, should you not be able to profit some from all that investment you made? And I think you should. I think that's reasonable to do that. Now, you can argue where that date should be, what the time frame should be. And I don't know that I know the right time frame, but I think there is at least some advantage. It gives the companies an incentive to try to create new agents. And so I think that's a good thing, actually, overall. I mean, it sounds kind of tawdry, but I think that's, and what happens is the U.S. as a result makes all the new medications for cancer and most other things all over the world. We're much more successful at it because we incentivize the companies to do that.
Yeah, I did not realize that about generics and, the requirement of the medication before a generic is produced.
Yeah, we had a drug called Taxol or paclitaxel, and some people who have had breast cancer or something may recognize the name of that drug. It was released, we started using it in clinical trials in the late 1980s, and I was a fellow at the time. And then it became approved by the FDA in about 90, or no, it was later than that, about 2000, 2001, something like that. So if we ordered, if we, prescribed paclitaxel or Taxol to a patient, we made, say, $500 profit for us off of that dose. So we would buy it from the wholesaler for X amount. Then we gave it to the patient and billed their insurance for X plus 500, and the insurers would pay it. However, when the patent protection ran out after 17 years, whenever that was, then another company could make Taxol and the price dropped dramatically, and that profit went away. So that happens all the time.
Once the competition comes in. Gotcha.
Yep. So I think it's reasonable to give some degree of intellectual property protection for drugs like that.
Mm-hmm. Yeah. That, that the cancer, I know we're jumping back and forth, but the cancer natural treatments. I know a few years ago, I didn't read the whole book, but Chris Beat Cancer, I started reading that book, and it was just curious to see. I know he has a really big following now, others who have used natural treatments. And, that's a whole nother topic too, because that would be a whole nother episode, because, every body is different, and
I'll tell you, I'm all for it. You figure many, if not most, of the drugs that we use for various things. Taxol is a great example. Taxol comes from the Pacific yew tree, the bark of the Pacific yew tree. Because of that, we know there must be other agents out there that come from other plant species that we just don't know about yet.
Absolutely.
The problem is again, get back to this, there's no financial incentive to try to develop those things, because you can't patent a plant. So if you find a plant that has some thing in it, some chemical in it that works for whatever disease, you can't necessarily patent it. So therefore, no drug company is going to invest in it to do a clinical trial to prove that it works. So it's like a vicious cycle.
Gotcha. Yeah,
we
that again.
Do a clinical trial here's a good one, in ovarian cancer in the 2000s. And it was going to be diet and exercise alone for women with ovarian cancer that had initially responded to chemotherapy. In other words, you were diagnosed, you got chemotherapy, the disease goes away, but we know in that setting it's highly likely that it's going to come back within a couple of years. So we put them on this diet and exercise protocol, and we got that funded from the NCI. That was a federal trial, and it didn't work. The reason it didn't work, patients wouldn't go on it.
Yeah. Okay.
Patients weren't willing to exercise.
I can see that.
Yeah. So, there are all kinds of considerations in doing, natural or homeopathic remedies. There's all kinds of problems with it.
Mm-hmm. Are there any other, you had points, right?
Yeah, I was just nothing big. The things that I had were, one of the things that I looked up, and I was going to talk about this on the last show we had you on, was the asthma inhalers and what they cost people to, insurance wise and everything, as opposed to whoa, look at that. Look how I'm on fire. I'm glowing.
Ooh, kind of overexposed there.
I think you're more of an angel.
Maybe that's it.
No, that's not it. Anyway, there we go. And then opposed to Narcan, which I know some people get charged for Narcan, and it's a great drug to bring people back to life. It's just where does the medical industry draw, or the insurance, I guess, draw the line between something that somebody needs every day to help them stay alive, and that something that somebody needs maybe 4 or 5 times a weekend that they can't afford, but it's given to them
Yeah.
to save their life. And that's why I've never understood. It's like, I'm not going to say that you're being rewarded because you're a druggie. That's not what I'm saying. It's just that people that have to live their life every day with asthma and aren't getting their necessities taken care of over somebody that is abusing, abusing drugs and getting Narcan to be brought back to life, only to do it over and over again.
Right.
And I realize that we have failed as a people to take care of those people. Yeah, as a society, and taking care of those people and putting in places. I know some people don't want to be taken care of. They enjoy the drugs. They enjoy living that way, and that's
right.
If that's their thing, that's their thing, But what burden is that putting on the insurance industries, on the drug industries, on
all of us, because we're ultimately paying for it.
Absolutely, and that's okay. That's something that I was wanting kind of to touch on is. And it's not just with asthma inhalers. There's so many other things.
There's many other, lots of others. And I make this point in one of my other podcasts. It's an ethical issue. So we as a society look at health care, including an asthma inhaler or Narcan or whatever you want. We look at that as being something between a commodity that you buy and sell versus a right. So, in other words, should you just get medical care? Is that a right, or is it a commodity? And you can get that argument. I think most of us, however, if you're honest with yourself, for most of us, it's somewhere in between. In other words, we're not going to let people lay out in the street and die bleeding to death.
Right.
We're going to pick them. And the same thing applies to, say, someone who ODs, who overdoses on heroin or fentanyl or whatever it is. If you have Narcan available, which every ambulance does, they're going to give them Narcan. That would be unacceptable for them not to give Narcan if they suspected somebody was overdosing. Who pays for that? Well, we all do. And that's because we as a society have decided we're not going to let people just die in the street because they don't necessarily have any money or because it is somehow their fault that they do. We all do bad stuff to our bodies. We all do. Some people do a lot worse things to their bodies, but we still treat them. When do you decide who decides who you're going to treat and who you're not going to treat? That's the essence of it. It's a moral issue. So we as a society have decided that healthcare is neither fully a commodity nor is it neither fully a right. It's somewhere in between. Mahatma Gandhi said once, you could measure the quality of a society or a civilization by the way it treats its most vulnerable members. And I think you could say drug overdose patients are among the most vulnerable people in our society. We try pretty hard to keep them from killing themselves by overdosing. We don't always succeed, obviously. But I think that's a measure of our level of civilization, of society. And so I think that's legitimate. Yeah, it seems, unpleasant that some people are paying for other people who don't take care of themselves or don't seem to care. But what's the alternative?
Mm-hmm. And I think that's where the argument comes in. I know for a long time I was the let them die, if they're going to do that. But then I also heard a lot of stories of people touching something, and all beyond that and them going through it. And now, Joe Blow over here, who's a police officer, overdosed on heroin or methamphetamine. And for a fact that he touched something, or maybe not. There's been some instances where cops have taken methamphetamines they find, but
fentanyl is the example of that. It takes the tiniest little amount of fentanyl.
It's like a grain of sand.
Oh yeah, it's 100 times stronger than heroin. Mm-hmm. So you could just get it accidentally almost.
Right, and that's the thing you have to worry about now is like, say some kid who's a straight A, because I've heard these stories. A straight A student goes to a party, picks up something that maybe has fentanyl on it, or maybe they've never done drugs before and they do it for the first time because
Yep.
kids are kids and they OD and die, So that's another thing you got to put in your head is what
Yeah.
if, but then
What if it was my kid?
What if it was my kid? And then you also, because,
So who decides who to let live and who to let die?
I don't think
none of us can make that decision.
That's not our choice. Correct.
Yeah.
Here's a question for you, Rusty.
I believe is one of the most overlooked or questionable practices in the U.S. healthcare industry today that most people should be more aware of.
Again, I'm going to push promote my podcast one more time, but I think the most overlooked or misunderstood practice is the difference between, quote, health care and health insurance. Many people think of health insurance as if they're paying for health care. That's not what you're paying for. If you're paying for health insurance, you're paying for a reduction in risk. That's all you're paying for. In other words, insurance was designed to protect people from catastrophic loss that they couldn't recover from. It was not designed to pay your everyday expenses. So the insurance for health, the intent was if you had some massive accident that say a car accident, put you in the hospital for months, and it was wildly expensive, hundreds of thousands of dollars. That was the idea originally behind cancer or behind health insurance, not to pay for your prescription for insulin or your prescription for your high blood pressure medicine that you do every day and let thousands, if not millions of us take. But that's been conflicted. People don't understand the difference between health care and health insurance.
Mm-hmm.
I hope that makes sense, Verax.
That's a great explanation.
Again, everybody, I highly suggest subscribing to William's channel. She's entering something.
I can't put a link right now, but I'll put.
Yeah, I don't know how Gary does that.
That's how you can search for it.
So look at that. You'll find it right there. The Blues Doctor recommends
on YouTube.
On YouTube, just type that in the bar, and it'll take you right there. So
yes,
I don't think there are any more other blues doctors out there.
I think so.
There's a blues lawyer.
Right? Oh wow,
he kind of does the same thing.
Maybe you guys should start a band, Blues Doctor, Blues
Maybe
Lawyer.
so. Maybe so.
If anybody has any questions, it'd be great. This would be a good time. If not, then we'll probably end this. Rusty, thanks again a million. We appreciate it. I know a few people in here got on the Fauci talk. I'm with you. I know Misty got a little upset. I get it, Misty. I'm there with you. Rusty sees a different side of it because he knows Dr. Fauci. We see different sides of it as well. That's how we are. We think differently. And that's what I love about Rusty is he understands that, So, but I loved him talking about that. Thank you for sharing that. And again, everybody, if you have any medical stuff, Dr. Robinson, go to his thing, cancer. He was an oncologist. Hey, why don't you tell everybody what you were?
Yeah, I'm what I was. Once upon a time. No, I am trained as a gynecologic oncologist, which means that after medical school, I did residency training in obstetrics and gynecology, and then I did a fellowship, which was an additional 3 years in gynecologic oncology or cancer. So that was my primary training. My research interests include clinical research in general, particularly the underserved populations. In other words, populations that don't participate in clinical research, like Black Americans or Native Americans or women. In fact, particularly women was kind of my thing. In addition to having research interests in HIV and various other things. So I was in academic medicine for many years and just retired as of 2023, I guess it is, from Tulane in New Orleans. And now I'm out there just doing what I want to do now.
That's right. Absolutely. Enjoy it. Wendy said I will be coming over to your channel, Doc.
Great.
Oh, also, Verax had a question, I think.
What is it about the blues that can you speak across the areas and cultures?
Oh, I think the blues it touches something basic in all of us. In fact, I would say that people don't get this. Traditional blues and traditional country music are two reflections of the same thing.
Agreed.
It was very, poor or blue collar black people who created the blues, very poor blue collar white people who created country music, and they wrote about the things that affected them. Their songs were about the problems that they faced in their lives. And, we all still face problems in our lives. So we all need, some kind of respite from that. And maybe the blues provides a respite for many of us, or some kind of music or artistic endeavor provides some kind of respite for us from the travails of normal life. And the blues does that.
Rusty, we listen to tons of music, types of music. We're not country music fans at all. But anyway, just thought we'd share that. Love you all for the country music, but we're not. But one of the things that I grew up on was bluegrass. And finding out that as I was growing up, the bluegrass was part of the Irish Scottish. If you listen to a lot of old Irish, it sounds just like bluegrass. And it's the same thing as blues. It was all put together for basically these Appalachian people, these Irish folks, Scottish folk who moved into the United States to tell their stories. And that's what I always loved about it. The music was simple, but the words were meaningful. And I see the same thing with blues and early country music.
Yep. Sure. Simple but powerful is the way I like to say it.
I know Virax has another one here.
Mm-hmm.
In my perspective, what's one simple thing you believe every human being to stay healthy?
Exercise. That's the easiest thing, particularly if you're like my age or close to retirement age. Exercise like your life depends on it, because it does. When you sit down and stop doing things, at some point you're not going to get back up.
Mm-hmm.
So stay active.
Mm-hmm.
And Misty, I mean,
No effect on it again. Just can't help how I feel now. About you.
Misty, you don't offend me.
She offends me.
If you ever want to talk about it and we're ever together again, I'd be happy to, tell you even some more stuff about Tony Fauci.
Another one for you.
Answer.
I heard of many beating it the first time. Always seems to come back.
So the success rate for breast cancer is strongly dependent on the stage at which it is first diagnosed. In other words, if it's a small tumor confined to the breast, the success rate or the cure rate is probably in excess of 90%. If it's more advanced, or there's other features to that cancer under the microscope, and there's a number of them now that suggest that it might be more aggressive, then the cure rate drops in some cases to near zero. So it is highly variable. Overall, if you put all of them together, the cure rate for breast cancer, all comers, are the 5-year survival. That's the best way to phrase it, because that's the most data we have. The average 5-year survival for all comers for breast cancer is in the range of 50 or 60%.
Oh, okay.
But you could subcategorize that much more precisely based on stage, molecular markers, pathologic findings.
Do you think that cancer is bigger now? Like we see more cancer now than we saw 50 years ago, 40 years ago?
It's highly variable. Some we see less,
interestingly,
but some we see more. So, for example, the obesity-related cancers, and I talk a little bit about that in next week's podcast,
Awesome.
for example. But the obesity cancers are on the rise because obesity is on the rise in the United States. So breast cancer is obesity associated. Endometrial or uterine cancer is associated with obesity. Colon cancer is also, and there's a few other less common ones that are. So that for sure is. Interestingly, lung cancer has been declining steadily since the 1980s, and it's because so many people don't smoke anymore. The smoking rate in the United States has dropped dramatically. So lung cancer is much less common than it was 50 years ago. Cancer of the cervix, one of the ones I deal with, is much less than it was 60 years ago. And that's largely due to the invention of the pap smear. The pap smear allowed us to diagnose cervical cancer before it became symptomatic. In other words, when it was very small and we could treat it effectively. prior to that, we didn't find those cancers until they had bleeding or pain, and the cancers were much more advanced. So the Pap smear made a huge difference in that. So the incidence of cervical cancer has dropped significantly in the last 50, 60 years. So it depends on the cancer. It's up and down.
Do you think that, I mean, we've learned recently that the FDA is going to get rid of the food dyes in our food that cause cancer. As far as, do you tie that in with maybe the obesity issue because we're eating, crap food that they give us with crap things in it that are making us obese?
Short answer is yes. And the longer answer is we as a nation have allowed ourselves to use junk food or fast food, however you want to phrase it, as a substitute for good food, basically. Even look at other Western countries, you go to France and the rate of obesity is dramatically less, but the rate of fast food consumption is dramatically less in France also. So we take fast food, which has to be made cheaply. If fast food was expensive, nobody would buy it. So they use the cheapest possible ingredients they can to make that. So if you then find of those ingredients, they're probably not as good, and there may be issues associated with them that might, maybe not cancer causing per se, but certainly not good for you.
Right.
I want to say that. So yeah, I believe that's absolutely true. If the FDA goes after certain additives, including some of the food dyes, that will probably help.
Good.
Yep.
I know we live in a small town and there's a lot of big people here, but you have very limited food. It's a lot of lower income, so they're getting what they can. And I can't say that fast food's cheap anymore because you can go to Taco Bell and get what used to cost probably $8, and that was a lot. That was a lot of food. But now it's over $20.
Oh yeah,
and it's ridiculous. But
no, it is ironic that obesity is more common in low socioeconomic status populations in the U.S. than it is in upper or higher earners.
Yeah,
and it's a shame because like around here we have so many butchers and processing shops that you can have your deer processed. Local farms. I mean, there's so many, but the easy thing to do for a lot of people is just go to McDonald's, or to
go to the corner food store and buy, crummy snacks off the counter.
Absolutely. And whereas
in the cities, that's what happens.
Like with us,
food deserts where real grocery stores won't go because it's a bad neighborhood. So they have these little corner gas stations or whatever they are that sell foods that are not particularly nutritious. And people fill up on that.
And yeah, Jeff's got buy local meat. Well, yes, Jeff, definitely. But you're selling that local meat, Jeff. Come on.
Hey, everybody's got a gimmick, right?
That's right. Yeah, definitely local meat, vegetables, take care of your own, eat your community. That's what I say. Eat what your community's growing. It's there. We have lots of healthy foods here, and obviously with farms all around us, and that's what we do. We try to, we don't want cancer. We don't want any of these diseases that happen from eating crap like that. So anyway, I won't get off hand there, but
I want to say, first off, thank you to the moderators. I didn't get to thank you earlier, but we appreciate you. And Rusty, we love having conversations with you.
Thank you.
It's always a treat, and I highly respect you. I'm very thankful that you've been on here and shared your explanations and given your insight and your experiences. And I just appreciate you being open about that and also breaking it down into terminology, that we can understand as an audience. So everybody check out his page on YouTube, which is The Blues Doctor Recommends.
Gary put a link. I think Gary put a link in there somewhere. I'm looking for it.
Oh, there you go. That shows.
Yeah, right there.
That's his.
Yep.
So you can type that on the YouTube bar and that'll take you right to it.
Or search for The Blues Doctor Recommends.
Yep.
And you'll find Rusty.
And I would also like to say to my great friend Misty, honey, you can rant here anytime you want. That's why we have this site. That's why we're here.
Doesn't bother me.
I was going to say, we're not going to have soft people on here. So if you feel like ranting, I'm going to share it on there and you can rant away. That's what this is about.
Mm-hmm.
So, you can't talk about conspiracy theories without somebody ranting about something for sure. What's this one here? Hillary, I had a pack of ground beef. My husband got it Aldi, been in the fridge a month, still red. He got it. Yes, that's scary. That's scary.
Hillary, good luck. I think you said your daughter is the patient at the hospital now. So good luck with everything.
There you go. We got another subscriber to your channel. William. Ken, Wind Clan Ken, my buddy Kenny Shiver.
We and I are kind of neighbors too. So thank you.
Cool.
Awesome.
Thank you, Virax. Virax, you always have great questions.
Yes.
I don't know how you do it, but man, you are on great questions.
Yes.
Everybody, thank you for participating in the conversation this evening. I've been informed that we will not be having a show next Sunday because we're going to go play on the lake, I guess.
Yes.
So we're going to go swim and catch MRSA. Looking forward to it. No, we're going to go out
together.
We're going to go on a boat ride with some friends. So we haven't done that at all this year. So anyway, thank you, William. We appreciate it a ton.
Yes, thank you.
Please, everybody, check out William's channel, The Blues Doctor Recommends. You guys, you'll love it. If you love music and you love medical info like he was sharing here, I almost feel bad that he was sharing medical info because he was taking it from his show. But anyway, check it out. I enjoy it. Erica enjoys it. It's not a long one. It's usually about 15, 20 minutes long.
Correct.
So you don't have to be like, okay, I'm so bored. So
no, it's a great show.
It's a great show. Absolutely.
Well, hope everybody is well and you have a great rest of your evening.
Everybody enjoy the rest of your day. And we hope to see you in 2 weeks. I might try to do some shorts this week and see if I can accomplish that. I might ask some people on how to do it, but we might try that. So we'll see what happens. So thank you very much, everybody, for being here. We love you. Big love to everybody.
Yes.
And we'll catch you in 2 weeks.
Good night.
In the meantime, check out Rusty's show.
Yes. Good night, everybody.
Good night, everybody. See you, Rusty.